and estimation. And this is probably after 3 to 4 days. His investigations were all normal, except the count was 12,500. Renal function test, sugar troponin was positive, D-dimer was negative, and NT-proBNP was high around 2,500. So he was doing fine, admitted and treated very good. Third day he had non-sustained leak. He had some chest discomfort. This was not very typical. As he had non-sustained leak, he decided to do angiogram in these patients. What you can see here is degree of dark, and this is a left side. Circling is okay. The right, the left LAD, there's a dissection involving proximal bleed, LAD diagram. This is a case after 7 days. As this patient has consistent decay, I thought I'll just try to open the crystal LED while taking care. And the most important thing is you should place the wire in the tube. Either you can do pass the wire, use the microcatheters, check the pressure. If the pressure is fine, then you're sure that we are included. Or you can pass the wire into diagonal branches. So I tried to dilate the balloons. The two infections I could not do. So this was the picture. I thought, okay, I'll leave it like this because I'm not going to test these patients. And if I do intervention in this patient, I do not know what strategy to take in this patient with a scan involving long segment of LED and diagram. There will be a lot of talk with hydrous and OCT. We don't have OCT. And I do not dare to do hydrous in this patient who has spontaneous coronary artery dissections because I'm not very expert in doing hydrous and not expert in treating patients with scab with heart patient disease. So I was transferred to ward, and this patient looks fine. 3 hours later, he had sustained decay. He had to be defibrillated a couple of times, 6 or 7 times. Went into ventricular shock and fibrillations. So this patient had a VT, flutter fibrillations, defibrillated, electrolytes were normal. He was intubated, put on inotic support, gave IV magnesium, amiodarone, and with these medications he became stable. Blood pressure was 90 or 60. Now the question is, how should I treat this patient? Did I do something wrong with this patient? Or it was hypersensitive, or it was a disease progression? So let's share some of our experience with this case. This is a 24 years old lady. This was case presented 5 to 6 years back with ischemia. She had irregular menstruation. So she was trying to conceive. She consulted with gynecologists. They gave me 2 cycles of estrogen and progesterone. In the second cycles, when she was taking, she had ST remission MR with 8 hours of chest pain. Then this patient was taken to catheter, passed the wire, tried to dilate the balloon with the repeated tonal suctions. The distal flow was moved. We left this patient and did check angiogram after 3 months, where you can see recognized after. So this was a case of spontaneous coronary artery dissections. We all know that spontaneous coronary artery dissection may occur in 4% of the patients presenting with stain. And this is more relevant in young ladies less than 50 years. 35% of cases of scab without any risk factors, they present with epicarditis. This is the second case of scab in a 39 years old lady. She presented with end-stage with chest pain. And she had scab involving LED and diamonds. So decided to put a stent, and I'm sure there's a lot of discussions whether you should cover the left brain or just put in the posterior. So I decided to do stenting covering the LED posterior, not covering the left main. And this patient was asymptomatic. So I tried to see, check angiogram 2 years later. What you see here is there's some thrombus in posterior LED, and LED was totally occluded. And we often do get a lot of these sort of patients. So now the question is, we have a few experience of these cases. How should I approach this patient? If you look at this literatures, they say the clinical highlights, which is like if the patient has steady ongoing chest pain, patient presents with cardiac shock, if they have sustained ventricular arrhythmias or left main dissections, then we should intervene with these patients, otherwise medical therapy is used. And if you're doing stenting, there are different approaches. Some say just with over, or use cutting balloons, or if you're putting stents, use a long signal stent, or put a stent in 2 phases and then in between, go from proximal to distal, or go from distal to proximal. There are different strategies of putting stents. So, same like Khalil mentioned, the indications of revascularization in scat is steady, left main involvement, ongoing ischemia, hemodynamic instability, or sustained ventricular arrhythmias. Why people do not prefer PCIs? If you look at the data, the success rate is less than 50%. There's a technical difficulty in hospitals with 2 movements. There's a chances of extension of dissection or hematomatic extension causing side transoperations. Even if you put stent, there's a chances of hematoma progression and loss of vessel flow. Even if you put a stent, once this hematoma resolves, there's a chances of stent malposition and stent thrombosis. Let's look at the data from Liverpool. The technical failure in STAT is 53%. 13% they require emergency CNC, and PCI was 4% and 1%. Look at this largest study from Vancouver studies. The technical failure occurred in 36% of the patients, stent thrombosis in 6%, emergency CNC, and a complication PCI without this. The European study says 27% of the PCIs they resulted in technical failure. 9% of the patient required emergency CNCs. The most important is you have to look at the natural history of these patients. 95% of this contains coronary dissections. Angiography may be healed within 30 days. So my strategy was just observe the patient. Medical management, I do not want people to do angiograms because if you do angiograms, there's mix of dissection and progressions of that. So what is the goal of PCI in atherosclerosis, Capricorn syndrome, and SCAD? We all know that SCAD is not hospital. If it's a patient with atherosclerosis, Capricorn syndrome, the TV4 should be grade 3 and residual stenosis should be 20% of this. Whereas if you are dealing patient with SCAD, try to maintain for at least 1 day more, and residual stenosis less than 50%. So this should be 8, and this is a treatment strategy. So this is how we treated patients. And this patient was extubated next morning, doing fine. Discharge on 6th day, his ejection fraction in emergency was 35%, and during discharge also was 30-35%. And he was treated with yes, there's a definitely statins, ACIs are controversial, but this patient has low ejection fraction, there's role of ACI. And one important blocks in statins has been beta blockers, but this patient has LV dysfunctions. So he needs ACI, ARD, and renal corticosteroid. So this patient went back home and did CT angiogram. It showed dominant right coronary arteries. There was severe 70 to 80% lesion in LAD. There was infarction LAD territory, mild vessel in coronary arteries, and small penetrating ulcer in distal aortic arch. We all know that SCAD is associated with fibromuscular dysplasia involving cerebral, renal, and iliac arteries, other arteries were blocked. and he underwent cardiac MRI. Cardiac MRI shows ejection fraction was 36%. There was possible infarction in mid anterosegment, apical segment, anterosegment apex, intermediate infarction in basal anterosegment, and there was no stress-induced reversible toxicity. Following this, the patient is asymptomatic, and we capture this patient just to know how it's doing. So, take-home message is scan with left wing involvement, stevie, all-wing chest pain, or hemodynamic instability will require cranial aspirations. PCI results from scans are suboptimal and challenging. PCI should be performed by experienced operators. Conservatively, without revascularization, managed scan usually is completely over a few months. And the principle is keep it simple, safe. That should be both in patients with stable coronary disease with scan. Thank you.
Asking for a good presentation. That is a rare but very important issue because of the potential life-threatening. So, any question or remarks?
Arun, excellent talk. I just want to ask you, altitude has anything to do with how many SCAD patients you are seeing?
I think 7 or 8 patients.
I know, you are seeing a lot of SCAD patients. And in Nepal, why is it so high? Right, is it because the altitude has any?
No, the thing is, we used to see SCAD patients before. After I got a series of these patients, now my focus is more on SCAD, so we are not missing.
What do you think, Vinny?
I don't know about altitude, but I think you're 100% right. When you start thinking SCAD, you start looking at the angiogram a little bit more closely. And what somebody called angiographically normal coronaries was actually SCAD in some distal vessel, or SCAD in one view that you could identify and not in the other view. So I do think that if you're looking a little bit more closely at the angiogram, you'll end up identifying more SCAD than was appreciated previously.
Yeah, what we are seeing here is type 1 scan. The most common two-third is type 2, which is a long diffuse. And type 3 has a focal disease. So we need to see those.
Type 3 can be clinically, it can be angiographically indistinguishable from atherosclerotic coronary disease, right? It's part of the diagnosis of the vascular imaging with type 3 SCAD, from what I understand. I said that the type 3 SCAD can be angiographically indistinguishable from atherosclerotic coronary disease, right? So it becomes quite difficult to detect it without imaging. So we have a SCAD, I mean, we're lucky Jacqueline Saw is in Canada. She's promulgated a great deal of information on this area. I learn from all of the papers on a regular basis. And I wonder if there's a role for sort of collaboration and definition of different data sets on different sides of the world, because clearly this is a much more common entity than we ever appreciated. And you wonder if it's got sort of different origins in different places. What I notice about your patients and your cases, usually in North America when we see SCAD, they're in fibromuscular dysplasia patients. And the classical angiographic appearance of the distal vasculature is hypertortuosity. But your patients didn't have that much hypertortuosity, yet they still had SCAD. So it makes you wonder whether or not they're actually a clinically unique entity on this side of the world.
But this patient did not have a fibromuscular dysplasia.
Yeah.
2 other patients, they have fibromuscular dysplasia. I'm not sure.
We're very aggressive for screening for it now when we see these types of patients, and the hypertortuosity is like, it's unmistakable. You just know right away when you're looking at one of these. Either they're horribly hypertensive, where then they carry the usual risk factors for that, or if they're young and they have this type of hypertortuosity, immediately you're like, there's something very wrong here, and we start putting them through a workup. But these patients didn't have as much of that, so you wonder if they're fundamentally different.
Yeah, we need to do more follow and food in these patients.
Definitely, there's a SCAD registry that perhaps collaborate on between the U.S. and Asia. That would be really great.
So I want to ask how should be the approach? You know, if you have a spontaneous dissection, if there is good flow, I think we can wait, right? If there is no ongoing ischemia, and if the patient is okay, there is good flow, then we can wait and we can check it after. But if we have thrombus after dissection, and if there is no flow, when you do balloon dilatation, do you think it's enough, or you would like to go by stent in that case?
Well, treating those patients' scats requires a lot of technical skills and expertise. If you are confident, you should go. If you don't have confidence, like I did a few cases of scat, and I had a couple of mishaps treating all those patients. So based on my experience, I'm very conservative unless the patient presents with sting.